I have to say dear all in the gentle neutral way since we use that. I'm a bit moving around. Sometimes I will skip some of the slides because otherwise it will be too much probably, but we will see how you react on it. Just in the beginning, when I give lectures, it's just pulmonology is a very technical study, and I just want to introduce that one of the weeks I was working in the department, we had lung function where there's a lot of techniques, diagnosing asthma with electronic nose, aerosols and tuberculosis, how to keep clean air in the rooms, pacemaker and radiotherapy, was it interference, laser treatment of a malignancy, we did laser treatment in the airways, prosthesis used in the airway, so we had something introduced in the airway which was nearly blocked, liquid oxygen and problems, MRI and pacemaker safe, embolization with coals when there was a bleeding in the lung. So it is a kind of job which is very connected to techniques. And we have Frans de Jong, which is an engineer in air, how you call it, air studies and airspace studies, and he did not take the big airways, but he took the small airways of the lung to come to work. University of Twente had always in his logo the high tech and human touch, and I used for this lecture inspiration, which is, I hope to inspire you, but it's also the beginning of a lot of things. When you look worldwide, and this is an old slide, but it's a very clear slide, is that most of the important causes of death worldwide were, in this WHO, the pulmonary diseases were here combined, but you always also see pulmonary infections, COPD and lung cancer. So if you take it all, pulmonary disease is the most common cause of death in the world. And inspiration started with Dürer. Dürer was a very nice, and he says, God inspires life in Adam. And that means that is actually not the way we breathe, since inspiration is to suck air into the lungs by active contraction of the diaphragm. And the diaphragm is very important in COPD. It is also in flare, divine information, and it's also inspire, and that means that you encourage someone now. And since I need inspiration for all kinds of things, my big inspirator was our Dutch Nobel Prize in chemistry winner, Bernard Veringa, who said, science is fun. And I think a lot of doctors should find out about that. Since I did science, my work was a lot more fun. That's a small introduction. What actually the topics of this lecture is the inspiration of smoke and its consequences, since that's the beginning of a big part of COPD. Inspiration of allergenic materials, inspiration of medication, and inspiration of microorganisms. But I will not take all the topics completely. I will just touch them, and I will focus me on COPD. The assumptions is at inspiration, particles enter in the lungs. And the smaller the particle, the deeper it gets into the lungs. So that's which particles do participate and where. When you see at the basics, you see the particle diameter, and you see the deposition, and you see that particles who are too big will not deposit in the lung because they get blocked in the upper airways. But the lower the smaller you are, the deeper they get into the body. And then I show you a tree, and this tree is in my garden. It's a tulip tree. They call it tulip tree. And when you do this, then you will see something which you meet here, which is a lung. And this is a soaped lung tissue skeleton. The skeleton is left after you soap the lung. We will tell you that it is used, why it is used for that. And it shows the complexity of the pulmonary tree. When you know something of trees, you should read this book, which is The Hidden Life of Trees for Peter Wohlleben. And Peter Wohlleben told me how trees work. And what I'm going to tell you is something to tell about a lung tree, and that's the goal of this afternoon. The airway has a lot of branches, and you see at the left, for you, the left side, you see the bigger airways, and after 23 deviations, it comes to the air bubbles, the air small alveoli, they call them, and the alveoli, there is the place that's like grapes. It's the place where the gas exchange takes place. So the inspiration of smoke and its consequences, what does that mean? Every year, about 20,000 persons die of smoking and several thousands of passive smoking. I will tell you something about that. Smokers die about 10 years earlier than non-smokers. And half of the persistent smokers die for consequences. And this Mr. Marlborough was actually killed by lung cancer, and he claimed the Marlborough company because he had to work with cigarettes. So it's real life. The important thing is when you speak about COPD, you speak about smoking. And I think even when I did my PhD study, I did on self-management in COPD, one of the important things was that when patients stop smoking, that has a major impact on quality of life. And when you do a study on quality of life, I think you should start with a smoke intervention, since when you have your intervention and people stop smoking in the study, the results are probably mixed or biased by the effect of smoking cessation. So we did, before our study, before start of a study, all the patients were asked or if they would like to have a smoking cessation intervention. And we did, and afterwards they run in our study. The most important thing is, if you do not manage to stop, what does that happen? What does happen? And it's a difficult, nasty feeling and ashamed. And what we try to do in our research, and that's the COPE-1 study. We have now COPE-3 already and some more studies. That was COPD investigations, that's in Dutch, onderzoek, pulmonology, Enschede, Department of Pulmonology in Enschede. That was my PhD study, and there are now already 3 studies after. What I told you is that before the study, we started a smoking intervention, and we were very happy to give a very good program. Of course, we made it ourselves. There was no experience in stop with smoking studies, so we were one of the first. And what we asked some advices from groups of who dealt with addictive people, like cocaine and heroin, and they learned us a lot about how to deal with those persons. And we were very proud, since we had a kind of results self-reported after 9 months, was that 54% of the patients had stopped smoking. That is the best result you will ever see in literature. But I doubt it. I saw the patients, or my outward patients, and I always told them, you live in a smoky area or a smoky environment, since I still smell smoke, you know. And so I spoke with some of people of the department of the pharmacy, and they did research with the dentists use those swabs in your mouth, and they can suck all the saliva from your mouth, and the saliva, if you extract the fluids from that swabs, you can check nicotinine. And we did a check of cotinine, which is a stable metabolite of nicotine. So if someone has smoked last week, you will find still cotinine in his swab. And we did, and I can tell you that the results after 6 months were 36. People said to me, I'm stopped, and then after our test, it was only 12%. So that does mean, what I learned from that is that patients liked our program very much, but smokers are cheaters in a way. There's a lot of literature now about cheating, but you should know that smoking is part of the disease you are studying, and it's so basic, it's so hard to get it out of the mind of the people, and it is because why is it? Because in 8 seconds, a nicotine goes to the brain and has neurological effects which makes you feel happy with dopamine and all kind of effects, and that's the problem. It's very hard to get the devil into the box again, since the people really want to stop, but they are heavily addicted, even more addicted than people who smoke heroin or cocaine. So it's a very hard way to intervene. And why is it so difficult? Because the cigarettes are really mixed with all kind of stuff to make it enters faster in the brain and to make people more addicted. So you will not believe what's all put into the cigarette. But another thing which is very bad is that they made in the test machines to be tested in the labs for nicotine production and so on. They were tested by the government, but what the companies did is that they made small holes in the filter, so in those test cigarettes, so that there was a lower amount of nicotine in the testing cigarettes, apart from the official cigarettes. So because the people put their lips on the filter, and then they block the holes. So that's the reason there's a lot of cheating, and that makes it's like the Volkswagen cheating. It's a kind of way they try to avoid comments from official sites. Because we want to have people get away from smoking, there has to be behavioral change, which is a very difficult part of intervention. To change doctors is even worse, that they deal something different, that they act different. But it's also important to know that this is one of the most important ways to get rid of smoking. Children are the biggest problem in smoking problem, because when they have smoked one cigarette, they're already addicted. It's very difficult to get to prevent children start smoking. Another problem is the example function of elder people and the reduction of selling points of selling short of cigarettes. And one of my colleagues is an anti-smoke activist, and she has done all kinds of things to get this done, because it's one of the basic interventions in COPD. What we have done is 2 intervention studies in COPD, 2 PhD studies in smoking cessation from our department. We have a stop smoking department, and patients go there for interventions in the hospital. It's the only hospital in the Netherlands I know who is actually having a stop smoking department in the hospital. We had children's stop smoking programs at schools. We went to the schools, and with the second primary, the children who just went from the primary school to the secondary school, and we did the intervention together with the teacher who was smoking with the children. It was very interesting. The results were very, very special, because they understood each other very well. What we learned from that is that when you put people together with the same disease, with the same problem, like COPD patients in a group meeting, and they meet each other, even when they are director of CFO of a CEO of a big company, when they are together with a worker, they will have a lot of emotions to exchange, and they will speak the same language in their disease. And we had beautiful experience of very educated people who were smokers together with workers, and they all had a very good way of exchanging ideas. They had the same problems. Another problem in smoking, which is just important to know, I think, when you deal with COPD, is pregnancy, and smoking in pregnancy is a real major problem and very hard to treat. And we have a stop smoking clinic in our hospital. We got several grants, and we got. I was able to get a grant to 70K in Pioneers in Healthcare Innovation Fund in 2018, and we did a VR intervention in stopping smoking. So we brought the patient, intervened them with virtual reality environment. We offered them their cigarettes, and we did all kind of research on the patient, what happened when they were exposed to their cigarettes. And that's to learn more about patients and then to be able to intervene. That was one of our things. What if you do not manage to stop? So a lot of patients who continue smoking, about 15% of the smokings get COPD. So that's, if you look at it worldwide, you will see that COPD is a real major problem. I will tell you something of the genetics, and I will tell you about a cohort. The anatomy you have already shown, but when you are at the alveoli, the small bubbles in the lung, you will see that this is a very tiny wall, and the blood flow is just goes here, and the carbon dioxide goes out and the oxygen goes in. And this is when you cut through a lung, you will see that the lung looks like with all kind of small holes. The small holes are the airways, and then you see all kind of tiny air places, and that are the alveoli in the lung. Cumulative exposure to noxious particles is the key risk factor for COPD. Cigarette smoke, indoor pollution, occupational dusts, organic or and outdoor air pollution. We know that children who lived in the southern part of Netherlands, in Maastricht, and they had a big highway going through the city, they did test in those children compared to children who lived in the other part of the city, and they found there was a huge accumulation of presentation of asthma and obstructive lung diseases in those children. So it works on the airways. Why does it work? Because the distance from the outside air and the blood vessel is about one hair thickness, and that means that anything what comes in by smoke and is airborne will enter to the small airways and will enter into the circulation. And when you have a normal structure of a lung, it's all attached to all kind of attachments, and the airway is held open. As soon as you have a serious chronic obstructive disease, you will see that the attachments are broken, that therefore the circular wall is shrunk. There's a lot of I will tell you how that happens, mucus hypersecretion. That means that the airways are narrowed, and that's one of the major problems of COPD. So this was the nice lung, and this is the lung of a COPD patient. When you do an autopsy, you will see that there are, instead of the small spickles air spickles in the lung, it's completely black, and there are big holes, and that means that's a destroyed lung. So this is quite impressive, I always think. COPD has, when you diagnose COPD, you speak about symptoms, cough, sputum, and shortness of breath, and you have the combination. You need a combination of exposure to risk factors, tobacco, indoor air pollution, occupation, and outdoor air pollution. And then you do a spirometry, and after spirometry, you get the diagnosis COPD. In the end of the last past. It's at the 90s. We had the first. We had the first group who put all world COPD knowledge together in the Global Initiative for Chronic Obstructive Lung Disease. And when you got that, you will understand that this is gold. Gold is a very important thing in COPD to understand. And then you come to a terrible definition of COPD, because if you can't define it just in one sentence, but you need a whole page of defining a disease, it means that there's still very little known. COPD is preventable and treatable disease. Okay. Significant extrapulmonary effects. That's one thing of resample that may contribute to the severity of individual patients. Its pulmonary component is characterized by airflow limitation that is not fully reversible. So there is a chronic part of it, and the airflow limitation is usually progressive and associated with an abnormal inflammatory response to noxious particles and gases. That means mostly smoking. So some figures, this is the figure which is now 21, but you will see that in the 90s already it was predicted that COPD would be the third cause of mortality in the world, which is even more progressive since ischemic heart disease and other vascular diseases are better treated, and they are less easy to die of, and COPD is only progressive. You can see here that all kinds of things, heart disease is going down over the time. This is 2002, but it's still continuing. Cancer is stabilizing. Stroke is better. Accidents are much better since cars are better protected. But COPD is rising, and you can see this here. There's an old slide, but still very interesting, is that you see everything is going down, but COPD is getting up. And it means that there is really a big problem. And then we did in the Netherlands. They had a big research in the GP population, and what we found is that especially the prevalence of COPD went up in women, and especially in women who are older than 65, and the groups of low socioeconomic status. So since the women are starting smoking after the Second World War, it has changed the spectrum of COPD, and we'll show you something about mortality later on. This is a very important thing. Since we spoke of socioeconomic status, we mostly think that 60% of the patients has low literacy in the whole Gauss curve, but in COPD, it's about 30 to 40% of the patients of low literacy. So any intervention you try to do in patients is you should always keep in mind that the person is low literate. So if you tell them to do a self-management program, you will always skip that population, since those patients are not able to deal with computers, with high tech and all those things, and it makes that it's very, very complicated that to start a study with low illiterate or low literacy patients, and you should always find out new ways to deal with that matter. And if you don't, you're not speaking about COPD, but you're speaking about a selection of COPD patients, and that's not real COPD. That's a big problem in your program, I think, to deal. How do you deal with the 40% low literate patients? And I have got some experience about that. How to deal with that, but that's very, very complicated. COPD mortality, I told you, women the amount of women is growing, and what we see is that the emancipation of man has shown that the number of deaths in 2000 was lower than at that time. The women took over the amount of deaths in mortality, and since then it has risen. And women have a more dreadful COPD than men. They have more. Another point is we have those passive smoking, which is in the bars and the restaurants and so on. And one of the major slides was from the Lancet in 2007, where they had the risk of exposure to passive smoking. And what you see that in the end, if you are exposed for more than 5 years, and they did these studies in Japan, for example, because there are a lot of people who live completely at home and they smoke at home, that you have 1.4 more chance to develop COPD. So passive smoking is really a problem. And another problem of COPD is the very high expensive. It's the direct medical cost is tremendous. The indirect cost, mortality related, is also terrible, but also the morbidity related costs are tremendous. So that is when you see what's actually in COPD, this is a slide of 2013, but what you see actually the healthcare cost of COPD, then you see that medication is a big cost, but the second point is the admission in the hospital, and that's one of the things you can avoid, and if you can avoid, the cost will go down tremendously. Physiotherapy, the specialist is not the biggest problem, or oxygen not, and then there are other points, but that's in, and this is the cost of treatment for an exacerbation. Ethnicity is an important factor in identifying the specific COPD genes, and they have big cohorts and they like to find out about what's going on, but it is a very diffuse disease, COPD. It's not like asthma, which is much more easy to frame and to diagnose and to treat. One of the things we know, there is something like a balance in protease and antiprotease balance disease. So if a protease are protein solvers, so they solve a protein, and antiprotease is something the body makes to prevent this reaction. And what you see that if there is a lot of protease, the patient develops emphysema, and antiprotease prevents to get you COPD. Why do you have those proteases? They are in the neutrophils, and the neutrophils are in the lung. That are the cells which fight all incoming particles. If you realize that the distance from outward to inward is only hair thick, it's easy that something enters the lung, and the body needs a lot of protection, and they do that with neutrophils. Neutrophils are kind of chemic bombs. They are full with proteinase. They can solve all kind of material, and if they lost their lives in the fight, they dissolve, and all the protease will come into the body, and they will start to demolish the lung, unless the body has antiprotease to prevent the resolution of the lung. So if there is an imbalance, and that's a genetic factor, when the proteases are not taken away by a deficiency of antiprotease, so if they are not around, there's several diseases in genetics, which patients who do not produce antiprotease. So when they smoke, they get already destroyed lungs at the age of 30, and yeah.
But there are there's no possibility that apart from smoking, so when you're not smoking and you have this.
Then you
can also develop COPD.
Then there is some destruction of the lung, but it's not. You have a lot of reserve so you manage to you will not have. Mostly you will not have a big problem.
Okay, so it's always a combination.
That's and an external factor of, but it's just one of the real genetic causes of COPD we know, and that's the reason I mention it. But it's so when there is more protease by smoking and there is no antiprotease, the balance goes to the emphysema. This is one of the most important slides I ever had. This was when I was traveling in Sicily. We make a bike tour around Sicily, and we were at Syracuse, I think it was, and me and my wife, and I saw here the typical COPD patients you could ever imagine. They are the smoker who is having heart failure because he has smoked too much. He is fat because of the edema he has. You see his legs are swollen, and he is enjoying the cigarettes. And the other one is this is the blue bloater, they call it like that, and this is the pink puffer. And the pink puffer is the fellow who is having emphysema, and he is the whole day respiring to get air into his lungs, and that means that he's top spotter. He's losing a lot of weight, and you see he is very lean. And I saw them too at the terrace, and I thought, I cannot make a picture of them directly, so I did as if I was a tourist. I showed to my friend, like a real Italian, I was there to let my wife take a picture of him, but by accident they took those persons on the frame. So we had some trouble at the lectures, and then I said, okay, we should give them this kind of, but then in Sicily, covering the heads with like in the Dutch magazines, that you cover the heads with blocks. It's probably also not nice. So I blocked myself also, but that was my experience in Sicily. But this is Job van der Palen used it in his inaugural speech as a professor. He used those slides. He said, "This is real COPD." And that's what the patient looks like, because in the lung there's a lot of destroying. Here the lung is completely destroyed centrally because of the smoke. The lung is full of holes, and if you see that under the microscope, you see there are all holes inside, and the lung, and the patient is just fighting to get his air in. He's the whole day an active breather, and he cannot eat against that, so he loses weight, he loses muscle power, and he gets more dyspneic. This is the fellow you saw there on the picture. The other one is the one who's a different type of COPD, who is just relaxing. Okay, let's come, and then he has heart failure, and he gets into that trouble. You see the arms are small, the ribs are small, and that's COPD. What Marjolein Brusse is doing is we had a cohort of all new COPDs we developed, and we tried to find out a predictor for morbidity and mortality in COPD. And she is doing now a novelty study and tries to find out biomarkers over time. So if you just do cross-sectional studies, you will miss a lot of information. But if you do long-term studies, then you will see, and over time, they will see that there is a lot of information. When does the patient start to begin to get trouble with COPD? What are the biomarkers to indicate that there is something wrong in the lung? The definition of COPD: terrible, airflow limitation, progressive, preventable and treatable, noxious particles, and extrapulmonary effects. Now, I think I should tell you some of those things, but one of the problems of COPD is that the small airways are attached in the lung and are held open at expiration. So when you follow this slide, you will see a normal patient, the inspiration, the airway is open. That's because we touched so the the airway is opened, and when they expire, then the airway is a bit narrowed, so the airflow goes even faster. But in the mild, moderate COPD, already attachment are a bit loss of elasticity. You see that the airway is already a bit narrowing. But at the end, at severe COPD, there is a loss of alveolar attachment, and at the expiration, the lung is airway closed.
Do these attachments break up because of all the proteases?
Protease and inflammation, oxidative stress from smoking, yeah. So the lung is destroyed, and the lung is having less elasticity. And that's what I show you later on in the testing. So the airflow limitation is not fully reversed. But what does this mean? This is a complex study, a slide where you see when you do lung function testing, then you can see that the patient starts. Try to get here. This is the normal breathing pattern, and then the patient starts to inspire completely. I was already afraid. And then it goes down, maximum expiration. There's always some air left in the lung, which is a residual volume, which is to keep the lung a bit like a balloon. When you have blown a balloon and you empty it, there's always some air left, otherwise it will collapse completely, and that's not possible, so there is always something left. And what we call this is the vital capacity. This part is maximum in, maximum out. And then the next slide, how do you measure lung function? That is, a patient will inspire completely and then in one time, and what we measure is the forced expiratory volume in 1 second. So what you can expire in 1 second, that's called the FEV1. And you can see normally about 80% of the volume can be expired in 1 second, but when you have an obstructive problem, you can only, for example, expire 40%. So it's not like that. That's the difference between the FEV1 in normal patients and COPD. So lung function tests, what actually happens is this: you can inspire, you can expire, and there's always some air left. But when a patient has COPD, there's loss of elasticity, so this goes very easy. But expiring, he can't get rid of the air. It's air trapping. And then when he is starting activity, he is breathing faster, so he starts breathing fast. And in the end, he is completely blocked because he can't get rid of his air anymore. So that's the major problem, hyperinflation in COPD. So normally you can breathe in and out. In COPD, you can breathe easily in, slow, it's loss of elasticity, but when you exhale, it will not be able, and it will take you a hell of a lot of energy to get the air out. So what we measure in FEV1, in the flow volume curve, that means that here you are completely expired, then you start inspiring, and here you start expiring. The big airways are not a major problem in COPD, but the small airways, there is the destruction. So this is a normal flow volume curve that you inspire, totally inspired, expire, and then the rest of the lung is a bit nasty to get it out till you are at the RV, at the residual volume. But when you have COPD, there is not a problem in this part, but the small airways are the problem. So the obstruction is in this part, and that means that that there is a flow volume curve which goes to the peak is still okay, but the lower part, then he can't get out. And this looks like a church tower presentation. That's that's typical for COPD, that the big airways open up, but the small airways, they can't get, they can't empty that. And the problem is that also because there is a lot of obstruction from the bigger air to get the air out, there is a lot of air left in the lung, and when you take some treatment, it opens up a bit so that you can have a bigger volume. So this is typical for COPD lung function measurements. It's progressive. Is it progressive? Yes. If you are smoking, then if you are not a smoker, a never smoker, then even when you grow older, the lung function goes down. But if you are a smoker, the FEV1 goes much faster down because of destruction of the lung. And there is a kind of disability line, which is this one here. And then you will see that if you are below that level, then you are really having big trouble to do any activity. If you stop smoking, then you will see that this part, when you stopped here, this part you already lost, but then the line will be parallel to the other line. So it will take a very long time to get disabled. So it is always worth to stop smoking, since you have big chance that you can deviate the smoking of the FEV1 decline line. Even when you are stopping smoking at older age, you have a chance to be better off for a while. It's preventable and treatable. This is a very interesting study, a very major study and lung health study, 11 years results. And what you see, if you are a smoker and you stop smoking, then your lung function will go down, but will go down relatively normal. When you're intermittent quitter of continuous smokers, they will see that even intermittent smokers, there will still be some burning into the lung, and they will decline much faster. And this is after 11 years, so that's really interesting to see long-term interventions. Noxious particles and gases. What actually happens in the lung is that because of those noxious particles and gases, there is inflammation in the lung. So the inhaled particles, cigarettes, this in Dutch, sorry, air pollution, exposure, and the exterior air pollution will make that, because of the small distance from the outside to the inside, which is only human hair broad, this part, those noxious particles can enter, and here is the blood flow, the blood vessel, here is the outside air, and what happens is there is a big fight in that part, and all kind of white blood cells will come into the wall of the alveoli and start to to do their fight over there to get the noxious particles out of the lungs, and they get destroyed in the fight, and they get killed in the fight, and in the end they give the oxidative stress. So a normal lung is nicely attached, and this, what I showed you before, this is a COPD lung. And cigarette smoke has many effects. It's in the end because of host factors, because not everyone is getting COPD. There is a host factor, amplifying mechanisms, lung inflammation, because of the entrance of the smoking particles. It gives oxidative stress, and it gives a proteinases, which I already told you, which come into the body, and it gives the pathology of COPD. Of course, there are repair mechanisms, there are antioxidants, so there is a lot of factors which we still do not know, but 50% of the persistent smokers get COPD. And if you see that in what actually happens, that you see here a complete action of cigarette smoke at all levels, at the epithelial cells, at all kind of reactor cells in the lung, and in the end it gives fibrosis in the lung. That means that there is a lot of scarring, there is destruction of the lung emphysema, and because of the prickles, the prickling of the airways, they get a lot more mucus production. So in the major airways, the large airways, there is mucus hypersecretion, there is glands hyperplasia. That means that they will enlarge, the cells will get infected, and this is number one in the major airways. In the small airways, the attachments, you see they are broken. There is exudators fluid getting into the lumen, which is thick and sticky. The thickened wall, because of the infection, the wall thickens, so the lumen, the air space gets smaller, and there's all kind of reaction around. So that makes the destruction of that level, and this is in the small in the alveoli, that's alveoli, that's the small air bubbles. You see that the wall is destructed, loss of elasticity, destruction of pulmonary capillary bed, and inflammatory cells. So there are a lot of more cells into in the lung, and they in the end destroying the lung. But also the activation, oxidative stress gives endothelial in the big vessels of the lung. They give all kind of destruction, and it makes that there is in the end a thickening of the wall, and that means that the pressure in the lung vessels is getting thicker. That means that there is hypertension. Hypertension, you know, from the systemic blood flow, but also in the lung there can be hypertension because of the thicker walls and the smaller volume of the vessels, and that means that the heart has problem to get the blood through the lung because there is less. It has to push harder to get it through the lung, and in the end the heart says it's enough, I am not able anymore, the blood cannot be pushed enough to the lung, and the patient die or get the edema, so the fluids stay into the tissues because they can't get through the lung. And that's the fellow you saw at Sicily picture, where he was really having the blue bloater. That means the purple person who is purple because he can't get enough oxygen into his body because his lungs are destroyed. So inflammation in COPD, small airways disease, airway inflammation, airway remodeling, and parenchymal destruction, loss of attachments, decrease of elastic recoil, and that all leads to airflow limitation. And in the end, what I showed you, so if you have severe COPD, the airway is closed, the air is trapped. It means air can't get out, it's trapped, it stays in the lung. It means that the patient has to work harder to get his lung into action, and that means that the health status is getting down. Extrapulmonary effects. The systemic inflammation, since it all enters into the lung, all those toxic products from the lung into the vessels, and that means that there is a big effect on comorbidities, body composition, diabetes, gastrointestinal disease, osteoporosis, and cardiovascular diseases. And if the risk of COPD increases the risk for medical events. You can see here the relatively risk for all kind of diseases when you are having COPD, which can be tremendous, like all kind of cardiovascular disease and pulmonary diseases. This is a list of, you can read it later on, of all kinds of systemic comorbidities. You're dealing with that in your research, and you will be aware of that. COPD is a systemic disease, that's the word. Very interesting, this is a very new development. Mark de Kramer and Wim Janssens did that. you have in and this part you will see there is the smoking effect, and that gives oxidative stress, as I learned to you. And then in the end it will give COPD. And the other hand, you have the exacerbations, and which give also extra stress to the lungs. You have also problems with inactivity itself and poor diet, which is giving origin to arterial hypertension, obesity, diabetes mellitus, and hypercholesteremia. And this makes the other side also the comorbidity for COPD and cardiovascular diseases. So the interaction with those parts and the smoking makes that the whole body gets inflamed, gets oxidative stress, and in the end gets a high risk of arteriosclerosis, plaque rupture, and acute myocardial infarction and stroke. So the combination of those COPD, smoking effects, and the inactivity and poor diet, those combinations make the patient getting his comorbidities. I think this is a very important slide to understand COPD. Let me see what I have a small film that I should just to show off. I put it already into. No, this is not the one. So this is a patient with COPD, and what you see, this is when the patient is breathing and he is hyper. This is you see that he is very lean, and when he breathes, you see that the chest goes into his body. You see, when you breathe, it's like this. But when a patient has COPD, he is hyperinflated. That means that the diaphragm is pushed down because the air cannot get out, so he can't normally you breathe like that. But since the patient is having a low diaphragm, he can't breathe anymore like that. He breathes like that. You see, when you see such a patient, and I will repeat it once, you will see I took this from my office. I asked the patient if he was agreeing to do that. Why? How can I get it? Oh, there it is. And you see that when he breathes, he doesn't breathe like that, but he breathes like that. You see that it goes here. I put it down. You see that when he breathes, you see that it goes in. The diaphragm is pushing like that. The diaphragm is here till there. Normally it's here. So it is down, and it's moving this way. It's called the Hoover sign, and just when you look at the patient, you will see that the patient has COPD, has tremendously emphysema, which is part of COPD. Just look to the patient. So, come on. Nope. Dan moet ik die weer uitzetten. Even leuk. Yeah, I go. I get. It was this one. And then yes, there he is again. So the severity of COPD is expressed in gold, and the more severe, the higher gold classification, 1 till 4. But what is that? Okay, there's always an obstruction of the airways. Since COPD narrows the airways, there's air trapping, and it's difficult to get out. There are a lot of stages which are a worser FEV1, the forced expiratory volume in 1 second. If you are severely obstructed, you can't get a lot of air out, so the FEV1 will go down, or there's chronic respiratory failure. So stage 1 is very mild, stage 4 is very severe. But if you see all GOLD classification, this is a very impressive study, I think, is that when you saw a huge amount, 3,265 patients were checked, and they were asked, just tell me what are your complaints. There was no classification for COPD done in this study before. Afterwards they did, and they found that any patient with COPD, all patients, that walking steps, about 68% of the patient was not able to walk to take steps easily. Washing and clothing, about 1/3 of the patient was already into trouble. Light work at home, you see, at speech, at rest, 20% of all patients, GOLD 1, 2, 3, 4, they had already serious problems. So that means that the GOLD classification as we had was not enough. You need additional information. And it's not only the forced expiratory volume, but it is also the amount of exacerbations, of worsening of the COPD, which is important, but also the symptom score, which is also part of the disease of COPD. So the definition is difficult. There are a lot of work necessary. The classification is terrible, since you need A, B, C, and then in the end you end up with COPD GOLD class 1 to 4, and then group A, B, C, D, which makes it very complex to compare all kinds of studies, and you should always be aware that there is a lot of subclassifications, and then you know that a lot of patients are not joining the research since they are illiterate. Then I will tell you later that a lot of patients in studies were not taking their medicine. We did studies that about till 20-30% of all patients took regularly their medication. Of patients who are already taking part in a study, 1/3. So even when they are modified to take part in the study, and then when we check the use of inhalers by the Amico device, which is a device you can put on top of the inhaler device. You can see the direction of use, the frequency of use, how they use it with the flow, and they will see that about 10% of those patients who are already trained, taking part, are literate, are having COPD, that only 10% uses it perfect, it uses it okay. So that's a major problem when you're doing COPD research, that you should be aware that these kind of things are part of your study. And if you neglect them, if you take the smoking intervention into your study, if you neglect illiteracy, if you give them nice tablets with all kind of things, of nice programs, they will not take part, you will get lost into it, the program, and you will not study, you will not publish about COPD, you will publish about a very selected group of COPD. And I think that's one of the major things in research in COPD, that we first should be aware of what we are doing, what are we actually studying. And that's one of my, when I had an interview with you, I think I told you that this is one of the major problems I find into research in COPD, which is also in resample. And I recently published in a Dutch journal, I published an article where they had written that there is a national committee which is dealing with illiteracy and so on, and they said that the illiterate patients people will have more chance to die 6 years earlier than normal, the normal population. They will have chronic diseases for more than 15 years longer than patients who are not who are illiterate. And then we wrote a letter to the newspaper that even when we do that, what are we actually doing to bridge the intellectual clove of those patients, because that is not done in 1 year. That needs many years to solve, and we should think how we can get rid of all those www.netherlands.nl, which is for many patients in COPD is a major problem. And a tablet is a major problem for those patients. What we actually did when Marjolein and I did research in COPD, we had my patients, and I guessed that some persons were not that bright. So what we had a small, we called it a small box, which was a small computer we put on top of their television. We connected it with their television. We never told them that it was a computer, since when we told them it's a computer, they skipped no computer in my home. And then we had changed their zapper, you know, the switch which you use for the television. We call it zapper. I don't know how we call it in English. It's the tool you can change your canals and your voice, your remote control. Yeah? Now that one, we had changed that it could go through a whole program. All patients, even when they are very illiterate, look at television. They are used to remote controls. We got them that the remote control could only go to one way. It couldn't go reverse. So the patient went to the program. We used the A1 level of language. I don't know if you're aware of different language. When you speak Dutch in a proper way, you're a student, then you speak C2 or C1 anyhow. This was A1, a B1 level, small sentences, go right, go left, just two words together. And we managed to get patients through the program to do their self-management program. I think it was working perfect, but it meant that we went to the patient, we installed this mini computer, we learned them to put on the switch, not more, do not explain them all the things. And we had a very good backup office, which is very important. So they phoned and they did not get a technician who was just leaving the hospital or anything like. No, they got a person who was always reachable, and we told them to put the plug into the switch and so on. We found that the dog ate the cable, and we found all kinds of things, but it worked in the end. It means we were very near to the patients. We had a very simple solution. And because of success, it's never followed up. And Marjolein and I, we did nice publication. We had a lot of information of all kinds of patients. I tested them on the OPD, the program. So I took a patient and said, he's not that bright. Let him go to Marjolein. Marjolein tested the program and said, okay, I understand this is a bit too difficult. We should switch the sentence. We should do it different. We tested the next patient and we could change very fast, and we had a beautiful program. A lot of work for you to do. This is difficult. That worked, but I think that's the way you can reach a part of the persons in this patients in the program. Otherwise, they get lost. Okay, that's a bit of my belief. Okay. This is a very important thing, the FEV1. We were always speaking about FEV1 is very important, gold, 1, 2, 3, 4. And what I found out at the time, the correlations FEV1 with dyspnea, there was no correlation. Exercise tolerance, there was no correlation. Quality of life, there was no correlation. So we spoke many years, and still now in the definition there's a lot of FEV1. We saw the slide with the patients with all kinds of COPD who were not able to take steps if they were 1, 2, 3, 4. And we see this kind of correlations. We see there is a very poor correlation with all kinds of very important signs in COPD. Another point is very important, that if you have a small change in FEV1, 1 liter, 1.5, 2, 3. This is really normal. Here it gets worse. But the worse it gets, the higher the resistance, the airway resistance. So a small change here from in this region means that there is a major resistance progress. So this is what's happening in the airways. There's sputum, mucosal thickening, disrupted attachments, and then you get this patient which we already showed. What do we miss? And so what? Now, what I already learned to you is this is a very important part of COPD, when the air is not getting out of the airways and is getting lifted. There, it's a problem. The whole system goes up and it takes a lot of more action. So this is what I already showed. We did a kind of research in, I did it here, the technical medicine persons. We gave them a shirt where we could measure the hyperinflation, especially in activity. Testing dynamic hyperinflation is the hexoskin vest. And what we found here is that when the patient started to do activity, he was more active, and in the end you see that the residual volume, the amount of air in the chest when it was at rest, it was still possible, but when he started to do activity, that means breathing faster, and in the end you see that level goes up, and in the end it goes down. So you could give the patient that vest, we put him on a bicycle, and we could find out about the dynamic hyperinflation. So in rest it could be okay, but at action we could see that it was really, this was the vest. This is what are new therapies in COPD. Lung transplantation is the end. When the lung is completely destroyed, you can give them a new lung, survival till 7 years. Valves and coils, when you have a lung who is completely destroyed in some parts of the lung, and I will show you a small film, and then we have a small pause and we can see what we can do later on. And the other part is that because there is mucus hypersecretion, there's an overactivity of nerve, that you can block some of the nerves of the lungs so that the lungs are not cramping anymore, but that they are opening up, and that's new treatments. But the valves I will show you later on. Here, what happens when you have a lung where there are, for example, in the upper parts, a huge destroyed parts of lungs, it will be a balloon in the lung, and it compresses the other part of the lung. So what you do, you put a kind of umbrellas into the airways. I did it, it's not that difficult. And then the airway allows the air to go out, but not to go in that part of the lung. So that means that the big bubble, which is in the top, is losing air at the expiration, but at inspiration there doesn't get any air inside anymore. And in the end, that part collapses, and that means that the other lung gets more room to respire, and the diaphragm is less pushed down, so that the patient is getting better. So very nice studies. You can also do that by a kind of spiral, introduce a kind of, it's a kind of thing which is straight when you put it into the lungs, but when it gets into the lung, it's like a veer. I don't know the word in English. Spiral, yeah. So it collapses the part of the lung so that the lung is getting. And I will show that, and then we should have a power. I think even kijken. Escape. I have a small film to show you this.
The IBV valve system, a bronchoscopic procedure for treating emphysema. These are healthy lungs during normal breathing. Lungs with emphysema are overinflated and trap air. The IBV valve system is designed to improve some of the symptoms produced by emphysema. A medical instrument called a bronchoscope is inserted through the patient's mouth and guided to the lung areas targeted for treatment. A small catheter containing the IBV valve is passed through the bronchoscope. The valve is placed in the lung and self-expands to prevent air from going to diseased areas. The valves redirect air, but allow secretions and trapped air to pass. The valves expand and contract with breathing. Air is now redirected to healthier areas of the lungs. The valves can be removed if necessary using a medical instrument called biopsy forceps.
It's just an impression of a new kind of treatments for this kind of diseases. I will just leave this once. You can see here the results. So you can see here a huge amount of bubbles, and when they have put the valve inside, then you will see that this is complete and that the rest of the lung is okay. So the big chest, which was filled with air, was just relieved, and the patient could breathe much better. They do that in Groningen, in the University of Groningen. They were one of the first who did this kind of interventions. The other coils, you can see here that when the lung is all over a bit hyperinflated, you can just put those feathers inside and you just they put things together, and you will see they're all here. This is one of my patients. And this is new treatment in ultimate treatment in COPD that you take. This is a pig lung, and what they did, they put the lung into soap solution, and the soap resolves all the epithelial, so all the cells, and only the network, the frame of the lung is over, and then they put stem cells into this tissue, and they can make new lungs. So this is the lung which is in the end made a new lung for the patients with his own cells. So the frame is kept, and then they make new lungs for the patients with a stem cell transplantation. It's already working in mice. Exacerbations in COPD, that's even worse. I told you the definition is terrible. That when you have the exacerbations, an event in natural cause in a disease characterized by change in baseline dyspnea, cough, or sputum that's beyond day-to-day variations, is acute in onset and may warrant a change in regular medication in a patient with underlying COPD. You will not like this diagnosis, but it's still the one who is used, and it shows that it's so difficult to deal with COPD because it's so complex disease. It has so many different items. What important is that you always think when someone has a heart attack, after 2 years after hospitalization for heart attack, most of the patients only about 8 to 50% die within 2 years after a heart attack. But when you have someone admitted to the hospital with a COPD exacerbation, a lung attack, they call it, it's 35 to 50%. Half of the patients who were admitted in the hospital, nearly half, after 2 years will die. So that means that it's a major impact it has. And it's always a bit neglected, always, COPD, that's poor man's disease, you know. You had always heart disease that were prominent people were very important, and they had a big funding, and we have COPD, that's poor man's, low social classes, so there is no pope with COPD, there is no president with COPD, so there is no funding and no support for COPD, and that's a big problem. In COPD, inflammation in COPD, in the exacerbation, it's even getting worse. You get more oxidative stress in all kind of ways. And now this very nice study, but I did it with one of the students here, the technical medicine, and we found out that the color of sputum is always said when it's colored, it's a bacterial origin. And we found out that there is no correlation between the color and the bacterial origin. And that was the publication was not a lot of people did not like my publication because they thought their systems, their color charts and all those things could go in the waste bin, you know. But so they reacted on the publication with caps lock reaction that this was really not wrong and so on. But okay, we said okay, we did it. We showed it, and we found out that there was no correlation. There's another, when you have a patient at the outward patients, and it was the patients come, they are ill, and everyone starts on antibiotics. But since we knew that color is not a good predictor for bacterial origin of an exacerbation in COPD, we did with David Fernandez Rivas, and we got a grant to do a kind of light source intervention, looked at the oscillations of sputum, and we found out that there is different spectrum of bacteria, viral and healthy people. So we could do a differentiation between which kind of origin is for the exacerbation, and in this end we got a grant from Pioneers in Health for this study. I'm just busy now with a study in nanotechnology with Pepijn Beekman. He's just finished his PhD, and he is able to do in nanotechnical nanoelectronics find out if there is a bacterial origin in the exacerbation in COPD. And we had the program nearly ready, and then we changed to corona, since we found that if it's just a bacteria or a virus, we could also use this technique for viral identification. And we are nearly ready now to do a nano analysis of corona, of people sputum samples, and we can see if they are infected with corona, and we can see it much earlier and much faster and without low costs. So we can do it in 5 minutes, the test, and we have the results, which are very reliable. The nanoelectronics, why were they important? Because the diagnostic test we had for the color of sputum is not a good test. We give all the patients antibiotics waiting for the result for the sputum culture, so we give them all antibiotics. If you see 50% of the smokers have COPD, they get exacerbations 1 to 3 times a year. That means that they all get antibiotics. That means worldwide a huge load in resistance and all kind of problems. So we try to focus on which patients have bacterial origin and which not. That's research is still going on. Epidemiology and impact of exacerbations. Impact of exacerbations, patients with frequent exacerbations, and they have 1 to 3 a year, faster decline in lung function, poorer quality of life, higher mortality, and greater airway inflammation and destruction of the lung. So we try to reduce the damage and the frequency of exacerbations. Vaccinations could help. If you have a viral infection, the airway is the epithelium, the covering of the airway is destroyed and bacteria can enter easily. Predictors, we try to find out predictors of frequent exacerbations. We look at big groups of patients, and we've tried to find out which patients are really having frequent exacerbations and what kind of patients are they and can be prevented. We have, of course, self-management programs. It doesn't reduce the amount, the frequency of exacerbations in studies, but the the severity of the exacerbation. The patient will diagnose early, will act earlier, and in the end will probably have less burden of their exacerbations. Rapid diagnosis of bacterial origin, and we try to keep the patients out of the hospital, since the hospital is a bad place to be. There are a lot of site infections, a lot of exchange of infections. So the hospital at home, which is born in Great Britain, since there is not much money for hospital beds and so on, so they have organized it at home, and that's I think an important factor. This is from Malise, which is also one of the PhD students. They found the exacerbation in COPD study, that the only thing is that the days exacerbation are much less than the control group. So the control group had much more time and more heavy exacerbations than the patients who were in the end admitted in the hospital with an exacerbation in the self-management program. So they could not prevent the amount of exacerbations, but they could reduce the severity of exacerbations, and in that way reduce the burden for the lung. What we do now, that's also research, is that we try to smell exacerbations, and there is the electronic nose, and the electronic nose is very good to censor volatile organic compounds. These are small particles, organic compounds, which are specific for special diseases in the lung. And what happens if the VOCs induce swelling of polymers in the carbon particles in the lung, and when the patient is having an exacerbation with a special bacteria, then they will recognize that pattern of reaction of the VOCs, and in the end you can diagnose very fast an exacerbation in COPD. We can also smell tuberculosis, we can smell lung cancer, we can smell different types of lung cancer, we can smell also reaction of patients to chemotherapy. So we can smell the patient, and we can look at we can take the air samples and test them, and we can find out that this patient will react to chemotherapy and this one not. So all tests done in Enschede in our department. So the detection, I did a small test just to show the eNOS and Aspergillus. Aspergillus in the lung is a very bad disease. It is a high mortality. So what we did sampling from different patients at the intensive care, and we could find out that there was a very different pattern in eNOS packs in normal patients without Aspergillus and with Aspergillus. And in this way, we could react very fast, even before it was clinically obvious. We could react very fast in treatment in patients with Aspergillus infection. So you can smell with an electronic nose infections. Next, what is the trendsetter for future research in COPD? Self-management programs that you are just busy. Early discharge, get them out of the hospital. Smoking cessation interventions, earlier recognition of exacerbation in COPD, and lung functions in the third world. I did with some junior doctors. We gave them money to go to a technical shop and to get them buckets and pipelines, and they said, okay, you are now. I worked for 3 years in Nigeria in a mission hospital, very small hospital, 150 beds, but there is COPD. And how do you diagnose COPD in such a circumstances? And they had to, I give them a lecture on COPD, explained what was the major item COPD, and I told them, okay, you are now making a new lung function device to measure lung function in poor circumstances. And because they are not biased already with a lot of medical knowledge, they are like children, they are pure thinkers, they are not put into a kind of frame thinking. They are just free thinkers, and it was fantastic to do this with small groups of students and find out how they found out new ways to measure lung function in simple structures, a simple way. Telemonitoring, hospital at home, profiling in COPD, which is Marjolein doing, trying to follow up patients and to find out if they can tag the different types of COPD. Nanotechnology, electronic nose, adherence to medication, which is very important since a lot of patients actually do not know or use their medication. And what we try in this COPD program I developed, that it means that in one day you see a new COPD patient, you take all the information you can get, and in the end we try to find out prognostic factors to change in predictive factors, and that's what Marjolein is doing now. Now this is where we leave. This is all kind of, this is the Amico thing, you already work with it, it's very impressive. Now this is all kind of things, but I have just one slide I want to show you. This is a very good friend, Martin Partridge from London. He is really British, so he speaks a kind of English I would never speak. But the way he tells you, if you smoke 30 cigarettes a day and have a myocardial infarction, you receive sympathy, abundant health service resources, and research into heart disease is amply funded. If you have a similar nicotine dependence syndrome and you develop COPD, few speak up for you. You are fortunate if you obtain the few interventions that might help, and research is poorly funded and not always directed at key issues. That's really Martin. Martin can tell you the things that are really impressive, and I think you as a group are starting to change this slide, and in the future probably we say those heart diseases we know everything about, but now it's COPD, and I hope you are able to change the world of COPD by your research. Okay, that's enough for today, I think. Yeah.